Diabetic Ketoacidosis, DKA, is our topic for today. So let's start. So how do we define diabetes ketoacidosis? So it is a metabolic emergency in which hyperglycemia, which is high blood glucose levels, is associated with a metabolic acidosis due to greatly raised ketone levels. So what are some of the risk factors we already? So we have a mnemonic to help you remember the risk factors, the 6 I's. So we have 6 I's to help you remember the risk factors. So 1, we have insulin, infections, inflammation, infarction, iatrogenic, and also intoxication. So let's dive in deep into insulin. So when we have reduced insulin therapy or deficiency of insulin, in cases such as a known or undiagnosed diabetic patient, poor compliance, and also people who are not taking enough medications, also risk because they usually don't have enough insulin, so it leads to an increase in demand for insulin. Then the second one was infection. So in the bladder, UTIs, commonly you can have cystitis or pyelonephritis, which can also occur in some patients. Then in the lungs, we have pneumonia, which is very common. Then others, we have cellulitis. Then inflammation, we have the pancreas, a picture of the pancreas there, so we have, remember, pancreatitis, and we also have others such as cholecystitis. Then infarction, this is, just remember, infarction in the brain, CVA, your cerebrovascular accident. Then in the heart, we have acute myocardial infarction. Then under iatrogenic, we have we are going to have corticosteroids. Then of course we are also going to have surgery as iatrogenic part. Then we have intoxication. Then under intoxication, that's where we have excessive alcohol ingestion and drugs, for example amphetamine, cocaine, and of course others. Yeah, these are not the only ones here. Then pathophysiology. Now what happens is that in type 1 diabetes mellitus, deficiency or insulin dependent diabetes mellitus, there is an autoimmune response which attacks the pancreas, specifically targeting the beta cells of the iris of Langerhans, and when these are destroyed, there will be less insulin production. So when there is less insulin production, what's going to happen? There will be more glucose accumulating in the blood, so as it is termed hyperglycemia. So in DKA, so any event that further decreases insulin availability or cause increased insulin demand, increased production of glucose by liver, and an increase in glycogen degradation to glucose, thus termed genesis and glycolysis respectively. In the muscles, there is going to be decreased glucose uptake, and also there is also going to be decreased utilization of the same glucose by the muscles. Hence it will lead to breakdown of proteins. Thus patients usually become they usually lose weight because they are breaking down a lot of fats as energy. Then under the adipose tissues, there is going to be lipolysis, where there will be conversion of free fat acids into ketone bodies such as acetic acid, beta hydroxybutyric acid, and of course acetone, which will result in metabolic acidosis, which is the ketoacidosis and ketogenesis. And what's going to happen is that the body will actually have more like compensatory mechanisms. So if the beta hydroxybutyric acid and the acetoacetic acid are used for energy, they increase the pH levels, which means the blood becomes acidic. So the body would compensate for that by causing an increase in respiration. So the patient will develop Kussmaul's respiration, so they will have air hunger, and which is the deep and labored breathing as the body tries to move carbon dioxide out of the blood, and it's more like trying to reduce its acidity. But that's not the only mechanism. And the other mechanism is that we know that insulin, because it helps it helps potassium get into cells. So we know that beta cells are destroyed, so less insulin is produced. So there will be immediately when potassium ions are not entering inside the cells, there is hypokalemia in the cells, and there is a hyperkalemia in the cells just for a short period of time, and after some time the hyperkalemia outside the cells is usually excreted, but the cells intracellularly cells have hypokalemia because there is less insulin production, which usually helps in giving the body some, in allowing this happens because insulin stimulates the sodium potassium ATPase, which helps get into cells. So it doesn't happen because there is no insulin. Yeah, the ketone bodies, like we said, which are produced, they are usually broken down into acetone, and they escape as gas when the person is more like breathing out of the lungs. So when you actually smell the patient, they have a sweet fruit smell when they are breathing. So that's the reason why they have an acetone breath. Then we also have other things which occur in the pathophysiology. But and then we have clinical features of DKA. So we have polyuria, polygypsia, polyphagia, weight loss, nausea, vomit, leg cramps, blurred vision, abdominal pain, hydration, and the Kussmaul's respiration we talked about, which is your air hunger. Then also have hypotension, cold extremities, confusion, drowsiness, and coma, which usually happens in 10% patients. We may also have peripheral cyanosis, tachycardia, and smell of acetone. Then we also have investigations. So let's go through them. So we can do RBS or FBS, which is usually eye. Then we can do urine deep analysis. So we usually want to check for ketones, we want to check for glucose levels. Then we can also do our ABGs, which is our arterial blood gas, where we can pH levels, the serum bicarbonate levels. So you may find that serum bicarbonate levels usually below 10 milliequivalents per liter. Then pH 7.3. Then you can also do a serum electrolyte, so you can check for your potassium levels, your serum sodium. We're also going to do urine MCS, your BUN and creatinine, your full blood count, and also going to do your liver function test and your liver enzymes. And just you can type in the comment section the difference between the two, the liver function test and liver enzymes. So what's the difference between these two? Then also we are going to go through now the diagnosis of DKA, and that how do you make the diagnosis of DKA. So we have a lot of criteria. So we have hyperglycemia more than 11 millimoles per liter. Then you can also have electrolyte imbalance, so you can check for potassium, you can check for hydrogen, sodium, chloride, or bicarbonate levels. Then you can also do arterial pH, like we said, less than 7.3. Then the serum ketone levels, your ketones in urine. So the serum ketone levels, you may find that they are usually more than 3 millimoles per liter. Then ketones in urine, which is your ketonuria, as they have put, it's 2 plus or more. Then also you can do an ion gap, which is more than 12. For differential diagnosis for DKA, we have lactic acidosis, you can have starvation ketosis, alcoholic ketosis, and of course uremic acidosis, but of course there are others as well, but these are just some of them. Then finally we can do our treatment. So we have supportive therapy, where we just do our airway, we do our breathing, you check for any secretions, you do your supplemental oxygen, you put your IV cannulas for the next step, which is fluid replacement. So most preferable using the 0.9% saline, which is the normal saline. Then you give it for your local guidance. Then insulin administration. So in adults, we can use, if we are using the insulin pump, in adults you use 0.1 international units per kg per hour. Then in kids you can just give half of that, so you can give 0.05, or as local guidance, what the local protocols say in your specific area. Then for the next one, which is potassium replacement, so before you do, you give potassium chloride, which ranges from 20 to 40 milliequivalents. Before we do that, you have to check your serum potassium levels, because you can't just be given the potassium without knowing exactly how metabolically the electrolytes are. Then you do your treatment for underlying clinical conditions or triggers. If you're suspecting pneumonia or an infection, you give your IV spectrum antibiotics. Then you also treat other underlying conditions. If they are non-diabetic or what, you tell them to stick to their insulin therapy, they adhere to the medications and the like. Then you do your cross monitoring of the patients so that they don't relapse or they don't have rebound hyperglycemia or other complications. Then on the insulin administration part, so when you are giving the 0.1 international units per kg per hour, you have to make sure you drop the RBS by less than 5.6 millimoles per liter per hour. Then once the RBS has reached less than 14 millimoles per liter, you have to reduce the insulin. Since we are given by infusion pump, so you reduce by half, which is 0.05 international units per kg per 2 hours now. So we just want to keep the RBS in a period of 8.3 to 13.8 there until the patient is metabolically stable. So, and we also change the IV fluids. We go to 5% dextrose. We don't want to cause, like we said, rebound hyperglycemia. So if you are to fail to manage DKA, so what are some of the complications that may occur? So we have cerebral edema, your acute respiratory distress syndrome, your thromboembolism, your DVT, and which is deep vein thrombosis, your DIC, your disseminated intravascular coagulopathy, which is very rare, but it may occur. Then it can also result in hypovolemic shock or acute circulatory failure. Then we also have coma and hypothermia. Yes, so that's all for the DKA part. Then you have to do the clinical vignette, which is a PIDS case gotten from one of the pediatrics 4th years case, and it reads: a 10-year-old male presents to the emergency department with a 1-day history of vomiting, lethargy. She has a previous history of excessive thirst and frequent urination. The vitals on presentation are 37 degrees Celsius, heart rate of 110, respiratory rate 25, your blood pressure 99/65, weight, the weight is 30 kg. Then the labs were done, the pH was 7.05, your partial pressures for carbon dioxide was 20, then your partial pressures for oxygen were 100. Then you also have urine, which showed glucose 4 plus and ketones 4 plus. So the first question is saying, what is the most likely diagnosis? B, the risk factors associated with this condition Then C, you assess the child